Good afternoon. My name is Erik Lundquist. I'm a family physician who practices in Temecula, California and in Orange County. I'm delighted to be with you today, and I'm excited to share with you a few of my experiences and what I've learned about treating COVID long haulers from a clinical perspective. Hopefully, you'll be able to gain a few insights, a few tips, pearls, understanding that will help you in your practice as you take care of these patients who most desperately need your help. So let me share my slides here and we'll get started. All right, so just a little background on me. I graduated from family medicine residency program. I did it in the Navy. And after I completed my Navy training, I started practicing family medicine in Temecula. I then studied for the American Board of Holistic and Integrated Medicine, where I received a certification, and later sat for the American Board of Integrated Medicine. So I've been board certified in that, as well as Integrative and Functional the Institute for Functional Medicine's certification program. So that is my exposure to naturopathic medicine, which I'm excited to be sharing the platform with so many of you today, and hopefully getting a perspective from an allopathic physician will give you greater insights on how you can care for your patients. All right, so just some disclosures. I do some paid consulting for Metagenics Institute as an educational content consultant and guest lecturer. And I'm the medical director of the Personalized Lifestyle Medical Center, which is in Orange County and sponsored by Metagenics. And I'm the founder and owner of the Temecula Center for Integrative Medicine. Okay, so here's our objectives today. We're going to go over some basic facts, probably a lot of which you already know in regards to long haulers. We're going to go over some proposed etiology as to what is the underlying contributors to COVID long hauler. We're going to look at some testing, both some basic testing and maybe a little more aggressive testing that you can do to further delineate maybe what's happening. And then we're going to go over three patients, a mild patient, a moderate patient, and a severe patient. And you'll look and see how I manage these patients and get some insights into some management approaches, which will then lead us to the end of the lecture. And we'll go through some medications, some nutraceuticals. We will not have time to cover all of those that are listed. I tried to put on there basically everything that I had heard of or have used in regards to treatment of long haulers so that you at least have that as a reference. But we'll go through that, and please note down some questions, and we'll have some opportunity later to do some question and answers. The prevalence of long haulers seems to be somewhere between 10 and 30% of the over 100 million people who have experienced COVID infection at some point in time. The CDC recently reported that approximately 19% of patients who have had the COVID infection are still experiencing some symptoms. This seems to be the highest in percentage in the 36 to 50-year-old range. And we don't see it much in the pediatric population, though it has been close to 11% in 22 years and under. What are the most common symptoms? What you will see in your clinic, you have been seeing in your clinic, is this post-exertional fatigue and profound exhaustion. Patients will find that they're trying to get back into their life, particularly those who are athletes, and they try and exert themselves, and it flattens them. They are out for the next few days. So they literally have reduced their exercise, their activities to bare minimum. As you'll see from our patients, or the patients that I'm going to be talking about, they had pretty profound changes based upon exercise. We see sleep disturbances. Brain fog is another very common complaint. This neuroinflammation that's contributing to that, their inability to remember things, focus on things, concentrate on things is impacted significantly. Muscle aches and joint pain, shortness of breath, and dyspnea. There's this sensation that I'm still having breathing problems, even though Pulse oxygenation levels are normal. CT scans sometimes will be abnormal, but most of the time will be normal, as will check x-rays. Yet they still have this air hunger, this shortness of breath. Some experience chest pain and some heart palpitations. Not very many continue to have sensory deficits in either taste or smell. And we're finding that most of those individuals were really with that first wave of COVID infections. We're not seeing a lot of taste and smell disturbances with the most recent variants. And so we're not seeing that as much in the long haulers. One common kind of feature that is really bothersome is ringing in the ears or tinnitus. So how can you diagnose this clinically? Well, I think one of the most common complaints across the board is that when they exercise, it gets worse. So if you have a patient who you're trying to figure out if they have chronic fatigue syndrome, fibromyalgia, or post-COVID syndrome, if you ask them what happens to them after they try and exercise or even exert themselves going up and down the stairs, carrying groceries, doing laundry, if that really makes things worse, then there's concern that this is impacted from long haulers. And we'll talk about some of the reasons why we think that is. Brain fog is another common one. And then this kind of waxing and waning fatigue, where some days they feel a little bit better, even throughout the day they may have some energy, and then they kind of collapse. We're seeing a lot of POTS symptoms associated with this: autonomic dysfunction, dizziness, lightheadedness, heart palpitations, racing, anxiety. And when surveyed, 86% of patients experienced relapses triggered mainly by exercise, stress, or physical and mental activity. So keep that in mind, that even though they may get better and be doing fairly well for a little while, if they get into a stressful circumstance, they may see a turn for the worse and some of their symptoms recur. The thing that's making this a little bit challenging is that there's a lot of overlapping symptoms in some of these other chronic inflammatory response syndromes, such as chronic fatigue syndrome or myalgia encephalitis, POTS, chronic Lyme, SIRS or mold biotoxin illness. And then we see a lot of MCAS activation with these things. And these are some of the symptoms that can be seen associated with those different diagnoses. So how do you make the diagnosis? Well, it's not super easy because we don't really have a true test that says, oh, you've got COVID long haulers. So you just have to evaluate. Within the history, you want to know whether or not they have had COVID or think they've had COVID. By definition, they have must have had COVID for at least 4 weeks and recovered to some extent, and then are either having some lingering symptoms, or now having a new onset of symptoms that are clinically relevant to this diagnosis. Things that you'll want to do in your office as you're doing a physical exam on these individuals is check for postural hypotension, as well as tachycardia. Look for rashes, red eyes. Some may have some abdominal tenderness. You can do in-office lung function testing. And even though pulse ox will almost always be normal, sometimes with a little bit of exercise, you'll see it drop just a little bit. It's good to do just some basic testing, ruling out other potential causes that could be contributing to this: low ferritin, thyroid disorders, and then looking for inflammation, electrolyte imbalances, homocysteine elevations, as well as vitamin D levels, as we'll talk about later. It's an important thing. Some additional testing that can be done is through commercial labs. There's a cytokine 13 panel that Quest offers, looking at vascular endothelial growth factor. I found this kind of as a common thread among most individuals who have chronic long haulers. And you'll see this elevated at the end of their COVID infection, and then it stays elevated through long haulers until they start to improve. Not all of them, but I would say 85 to 90% of my patients, I'm seeing an elevation in their vascular endothelial growth factor. And then we're going to get into some of the theories, but one of the things that can be helpful is looking at their coagulation panel and identifying areas where there may be a pro-coagulative state, and then treating that can be really helpful from a standpoint. This is these are different commercially available testing that you can do, looking at different components of the coagulation cascade. I'm not going to take the time to go in and talk about each one of these, but I wanted to have this here as a reference for you. Dr. Ann Corson, who does a lot of teaching with different integrative medicine conferences, it does a great job of explaining this and teaching this and how you can understand it and then use it to your advantage to help patients get better. This is a test done by Dr. Bruce Patterson. Some of you may have heard of him. This is really the only test out there that actually has some science behind it in terms of identifying whether or not an individual has truly COVID long haulers. And if they have a positive long hauler index, which you see at the bottom of this, then you'll know that they actually have COVID long haulers. Now, in my mind, clinically, somebody can present and have an abnormal test, but a normal long hauler index, and still have evidence, which you'll see in our third case. This is actually her labs, and there's elevations in a few of her cytokines, as well as her VEGF, you can see, is pretty elevated from what it should be. So what are some of the theories associated with long haulers? Well, one of the theories is that there's an activation of pulmonary macrophages, and that this leads to this unresolved organizing pneumonia, which leads to continued respiratory symptoms. And the reason it's difficult to identify is because it doesn't show up like typical pneumonia, where you can see fluid in the lungs on a chest x-ray and identify oxygen mismatch. So one of the keys then in thinking about this will be then, well, how do we get these macrophages to calm down? How do we get some of the fluid out of the lungs? How do, in the interstitial spaces, how can we help improve overall lung function? And what is kind of leading to this persistence in their respiratory symptoms? Persistence of spike protein. There is several different studies that have been out showing that spike protein, even though the COVID virus is no longer active and has cleared the body, the presence of the spike protein or components of the spike protein can last for several months, if not over a year. This has been found in monocytes then and microglia activation, and so you get this perpetual inflammatory response, which should be calming down. Normally, monocytes will stick around, the non-classical monocytes will stick around for about a week, and then they'll disappear. But what's happening is these S1 proteins from the spike protein, which are being presented on these antigen-presenting cells of monocyte, non-classical monocytes, are staying active, and they're not disappearing. They're not shifting and changing despite the changing landscape of the body. And so this is perpetuating these symptoms. Interestingly enough, exercise induces triggers these non-classical monocytes. And so that's part of the theory as to why when people exercise or do some kind of activity, you get this upregulation of these non-classical monocytes that are now expressing the S1 protein, that's exacerbating symptoms. You get this then inflammatory cascade that triggers from that. As we know, the spike protein binds to the ACE2 receptor, and this then triggers a whole cascade of events within the endothelium. And we're seeing these clotting, microclotting issues, not just in the regular vasculature, but particularly in the cerebral microvascular. Excuse me. And this is creating a significant problem in dealing with these neurological symptoms. It can't be simply just, well, let's place them on some anti-inflammatories and see if this resolves. It's really clearing the clotting, this fibrin debris, this amount of fibrin degradation is not happening normally in the body, and you're in this pro-inflammatory, pro-clotting state. And that's leading to chest pain, it's leading to neurological symptoms, brain fog. And so stopping that and then clearing that out is key to resolving some of these neurological symptoms. Another one of the theories is that there's spike protein molecular mimicry. In other words, the body starts to produce antibodies against the spike protein, and there's certain protein aspects that on the spike protein that are similar to other proteins in the body. And this is then activating neurological symptoms and the adrenal gland dysfunction, leading to the autonomic dysfunction of POTS, and that may be contributing to some of the symptoms we're seeing with that. The other thing that happens is that there seems to be this increased stimulation of mast cells, particularly in the brain, and we're seeing evidence of these pro-inflammatory mediators then causing significant brain inflammation. This can be identified on a MRI neuroquant, looking at volumetrics, or can be used in functional EEGs, brain mapping, and seeing shifting in where the brain is functioning or hyperfunctioning. And this allows for tracking to see if the interventions that you're doing are actually helpful. We're also seeing a lot of rashes associated with this, some itching, and then this lightheadedness, dizziness. All of this is coming from this activation of the mast cells. And then, as we know, there's immune dysregulation that's occurring. And so there's some theories that what we're seeing is not just the spike protein contributing to all of this, but now we're getting reactivation as there's immunosuppression from COVID or from the spike protein persistence. And this is leading then to reactivation of these dormant pathogens such as Epstein-Barr, HSV, varicella, Lyme. And then this is contributing to this. In fact, some of the work that Bruce Patterson is doing is that they've identified when there's elevations of IL-8 on their long hauler panel, that almost a large percentage of these individuals have actually been associated with the recurrence of Lyme, or there's underlying Lyme, chronic Lyme issues that are complicating the chronic COVID or long hauler scenario. All right, well, let's go through 3 patients that I've seen over the past year who have had different scenarios, but similar scenarios. This first case is a 36-year-old woman with the following history. She was exposed to COVID and tested positive in August of 2021. Some of the treatment that she received was ivermectin, 12 milligrams, but it was started a little later in her protocol. She didn't actually start on it until 9 days after she'd started having symptoms of COVID. Then her symptoms seemed to resolve, and she was doing pretty good until around December. And she started having these panic attacks and started having some heart racing. In January, she ended up going to a cardiologist because of these just uncontrollable panic attacks, and it was disrupting her work and her family life, and she wanted to know what she could do. She also noticed that she had continued to or had not had return of her sense of taste and smell. She was having some hormonal changes, visual changes. Her gut function was not functioning as well. And this is somebody who is highly energetic and exercises a lot. And she was really struggling to exercise and was having pretty profound fatigue. She finally was made it into my clinic in March of 2022. Some past medical history and social history contributors. You can see she normally eats kind of a ketogenic diet, avoiding several of those things. On her review of symptoms, it was mostly notable for the fact that she was experiencing a lot of allergy symptoms, which she normally doesn't. She was having some cold intolerance and joint pain. And then we use a medical symptoms questionnaire that she scored 77 on. And normal for a woman should be less than 30, and somebody who's in kind of optimal health should be less than 20. So you can see her score is pretty high. Her vital signs were fairly normal, and although she was complaining of heart racing, her heart rate was only 74. But in somebody who's pretty fit, this was probably several beats above what her resting heart rate should be. So she was given a diagnosis of long COVID as well as chronic fatigue and anosmia and agustia, panic attacks, anxiety, heart palpitations, and hormonal imbalance. So these were the labs that were initially ordered on her, looking at potential causes. For those of you who do SIRS workup, you recognize the MMP9 in conjunction. I was curious to see if her joint pain and issues were maybe associated with an elevated MMP9. So what did I put her on? So I started her on some ivermectin, 9 milligrams, once a day for 5 days, and then twice weekly for 3 weeks. We'll talk about the evidence for that and why we do that. There is strong consensus among those who are treating long COVID, and some of the research is coming out that for women, for long haulers, 9 milligrams seems to be an adequate amount. You don't need to go higher. I know we go a lot higher when we're doing treatment for COVID. And for men, 12 milligrams seems to be high enough. She was also started on high-dose vitamin C therapy, about 50,000 milligrams plus 10 milligrams of zinc, followed by glutathione. And she received one of those treatments weekly for 4 weeks. Additional supplementation was specialized pro-resolving mediators, initially started at 3 times a day for 4 weeks. And then as the body was saturated, she was then dosed down, particularly the symptoms were improving, to twice a day and then to once a day. She was placed on high-dose vitamin D3 therapy, as well as some vitamin C and curcumin. By April, she was doing much better on her anxiety, heart racing, and fatigue, but still having some gut issues and some little bit still persistent anxiety, and had still not regained her taste and smell. And now she developed a new symptom of a rash and some pain with her legs. Her assessment showed that her MSQ had dropped from 77 to 36. And when we looked at her labs, you can see her MMP9 was elevated at 680. Her interleukin 10, which is an anti-inflammatory cytokine, was elevated, thus showing the body was trying to compensate for the amount of interleukin 10. And then one of the things we found in her hormone imbalance was an elevated estrogen. And then her VEGF, interestingly enough, was below normal, which we often see in recovery. So this to me is often a sign, okay, we're getting closer to recovery. VEGF is not as high. It would have been interesting to have had checked her, say, in January versus all the way in April timeframe. And then her vitamin D was not too bad at 46. Fibrinogen level was in the normal range, but on the upper levels of normal. All right, so then her new diagnosis, in addition to her previous ones, was this rash, looking to see whether there's a vasculitis component versus urticarial, and continuing to work on intestinal function. Continued her on her SPMs, continued on her high dose D3, continued her on vitamin C, and then added in some gut support with probiotics, apple cider vinegar, and digestive enzymes. And then in an effort to treat her anxiety, and then starting to wonder if there was some mast cell components to this, she was placed on sertraline, 10 milligrams. I think that might be a typo. I think that's sertrazine, and that should be sertrazine or Zyrtec, 10 milligrams, or loratadine, probably, maybe. But anyway, she was placed on some antihistamines and low-dose naltrexone if things were not moving, and then also quercetin, 500 milligrams, 300 times a day. Patient was then kind of lost to follow-up over the summer, mostly because she was doing so much better. She lived in Las Vegas, so she was had to commute and do telemedicine. She overall was feeling much better. She had an incidence of dysentery after a trip to Costa Rica, but when she touched base again by the end of the summer, all of her symptoms had resolved. She no longer had issues with her taste and smell, and she was feeling great, and she had stopped all of her supplements. All right, now let's go to case number 2. This is a 54-year-old gentleman who got COVID in January of 2022, had pretty high fever, profound fatigue, and went through quite a bit of treatment for his COVID. He was placed on hydroxychloroquine, ivermectin at 0.6 milligrams per kilogram, which is a pretty high dose. For 7 days, he took budesonide, fexofenadine, which is Allegra, famotidine, fluvoxamine, azithromycin for 5 days, dexamethasone, 4 milligrams twice a day, and promethazine. So he was hitting it hard because he was not doing well. He's a firefighter by trade and was pretty fit, and this was really, really frustrating him. 4 weeks after this happened, he had new onset snoring, had sinus congestion, was constantly dehydrated, yet he was feeling edematous. And then he was having these weird clots coming from his nose that were huge, and he couldn't figure out why he was consistently having kind of these bloody nose with these clots that were just coming out. He was still having issues with lung function. He was having irregular heart rates. He just really was not feeling good, and he was having some autonomic symptoms associated. His past medical history was someone who had SIRS, and he had issues with chronic bronchitis. He had been dealing with some kidney stones and had some kidney issues, high cholesterol. But he's, socially was non-smoker, ate pretty healthy, and drank occasional coffee. So for his review of symptoms, as already noted, he did have some rash in addition to the symptoms already noted. His MSQ was 70. I did a SIRS on him. It was 7 out of 13. So he was not manifesting typical SIRS symptoms. This was mostly long hauler symptoms. His heart rate for him, normally he would run in the 50s. He was at 88. His blood pressure was pre-hypertensive at 132/74. So he was given the diagnosis of COVID long hauler, immune disorder dysfunction. He had cognitive issues, brain fog. He had some exertional shortness of breath, chest pain, and he was still struggling with some issues with his left lower lobe pneumonia. So he's having this persistent kind of pneumonia despite having had antibiotics. So I ordered a variety of labs. I did order a few coagulation issues in there, see what was going on with the clotting, and started him on some IV therapy. Added some ozone in as well. Used the specialized pro-resolving mediators again 3 times a day, and then cutting back to twice a day and then once a day. We gave him some melatonin in a sleep support formula, and nattokinase, which is a fibrinolytic to help with the clotting issues, and then put him on an immune support formula and some topical glutathione. Gave him some propranolol, which is a beta blocker to help with his elevated heart rate. Used some nasal ozone to help with some of the sinus issues. Had him stop his budesonide, which is a steroid, and then put him on atorvastatin, which is a cholesterol-lowering agent. And anytime I put somebody on a statin, I'll add in CoQ10 because it is toxic to the mitochondria and can impair CoQ10 function and levels. So adding that in can be helpful. We discontinued his colchicine and his antibiotics. It took a little bit of time to get going, but by April, 6 weeks later, overall significant improvement. And he specifically noted that once he started the SPMs, that his clotting issues completely resolved. His sinus symptoms significantly improved, and as did his exertional fatigue and brain fog. However, some of his POT symptoms still persisted, and he was having some anxiety issues. His current assessments in his lab reviews, his MSQ dropped to 6. His abnormal labs showed an elevated homocysteine at 10, a fibrinogen level that was pretty high at 574. Here's the VEGF that's elevated. His interleukin 10 was at 6.4. His body was really trying to compensate for all of the abnormalities. His TNF alpha was 9.5. His interleukin 2 soluble receptor was significantly elevated. His CD57 natural killer cells were completely suppressed. So he was having some issues there, but a coagulation test of the prothrombin time was negative. He still was positive for the antibodies, spike antibodies, as well as the nucleocapsid. So he was still kind of carrying the spike protein in his system. So I kept him on the SPM, continued him on the immune support formula, and had him continue with topical glutathione, and continued with the CoQ10. And then he had some lion's mane at home, so we added that in there, and then bumped his D3 up significantly and used some phosphatidylcholine to try and help with some brain function, and then retested his labs. By July, so it took for about 4 months, but he was significantly better. Energy has returned, his clotting issues, he was feeling normal again. His final labs, his homocysteine levels went up a little bit, but his fibrinogen had come down. His VEGF, as you see, now dropped down abnormally low to 331. Interleukin 10 was on its way down. TNF alpha was better. His interleukin 2 soluble receptor resolved, and his comprehensive metabolic panel was within normal limits except for bilirubin at 1.3. All right, case number 3. This was a really still a challenging case. She isn't completely better yet, but this was an individual who unfortunately almost died from COVID. She had started COVID symptoms after her husband had tested positive in December of 2021. And despite trying to get a hold of some ivermectin, she ended up in the hospital and intubated due to COVID pneumonia. She was treated with dexamethasone, remdesivir, tocilizumab while she was there in the hospital. And then they were concerned about a superimposed bacterial pneumonia, so she was started on antibiotics. Fortunately, she made it home after 11 days on the ventilator. And in early January, I saw her and she was not doing well. She had multiple symptoms associated with COVID as well as COVID long haulers. And her past medical history complicated things a little bit, as she had a history of celiac disease, chronic lymphadenitis, polyarthritis, interstitial cystitis. And she had been somebody that we had treated, and unfortunately, this was part of the sadness of the case, is that she had finally gotten to the point where she was feeling about 90% of her normal self. She'd gone skiing the year before for the first time in a decade. She was playing pickleball. She was doing yoga certification. It was really, really sad. And then there was this huge setback. And as part of this, part of her challenge has been significant PTSD around her COVID intubation experience. And that, I think, has led to some challenges in her getting better, but she's been dealing with that marvelously, seeing a therapist, working on breathing exercises, actually also working with a shaman who has really helped her from a spiritual standpoint. So just remember that some of these patients who you may see, most of the long hauler patients will not have been hospitalized. But in some of them who have been, just keep in mind that there's a significant amount of PTSD that can be associated with their hospitalization. And there's so much fear and other things that have been induced by the media and our government in regards to COVID that there's a lot of anxiety surrounding this. So her MSQ was 63 at that point in time, but as you can see, her vital signs were not normal, with a heart rate of 120 and a blood pressure pre-hypertensive. And she wasn't obese, she wasn't heavy, but she was definitely having multiple issues. A whole list of symptoms is very typical for our clinic, 8 to 12 symptoms. So she was, because she was not able to come in for IVs, we started her on some B vitamin injections with some glutathione once a week for 12 weeks. And she was put on some D3, initially 5,000, then bumped up to 10,000. Vitamin C, zinc. She had some amino acid, branched chain amino acids to help with mitochondrial function. And then she was taking a lot of glutathione to try and get rid of some of the oxidative stress. And then she was placed on a endothelial glycocalyx support to help clear up some of the vascular issues. Over time, she started improving a little bit of her function. She was able to shower independently, but because of the PTSD, her anxiety was getting worse. And so we started some additional treatments. So we added in fenofibrate, which has been shown to help decrease VEGF levels and to decrease macrophages in the lungs. She also was having elevated cholesterol, so this was kind of killing two birds with one stone. And then she was having pretty severe pain and had been on Norco in the past, and so she was taking that periodically. This is what you'll see, just a slow progression in these individuals. She had progressed to the point where now she could take a shower, but still it was difficult just riding in the car, just coming to the clinic. And it seemed like as time was going on and the more we were trying to treat her and get her going, the more time away from her hospitalization, the worse she was actually feeling. In fact, you can see this, her MSQ went up to 81. Okay, I think we're recording in. Let me share. I think we lost connection there just for a moment. All right, we're back. So the fenofibrate, though, seemed to be really helping with her chest pain and heart racing and her ability to okay, I think we're back again. Lost internet connectivity there for a minute. So as I was saying, the fenofibrate really seemed to be helping with her lung function and her heart issues. But overall, still, she was feeling worse symptom-wise as her MSQ jumped from 63 to 81. So I ordered a bunch more labs, and in this case, I decided to do the Radiance or Incellex DX long haulers panel to see what was going on from that standpoint. She was continued on fenofibrate and hydrocodone, acetaminophen as needed for pain. And then we started on some CBD gummies to see if that would help with some of the neuroinflammation. By March, May, she's still struggling with symptoms of chest pain, shortness of breath, brain fog, difficulty concentrating, and heart racing. And now she was getting a rash, common theme, right? Now you've seen this multiple times as kind of this progresses. We start seeing elevations in mast cell and other vascular issues that are leading to these rashes. So interestingly enough, her long hauler index was negative, but on that first panel, there was significant elevations in her CD40 ligand, which is released by platelets, and her RANTES CCL5 was elevated at almost 13,000. Her VEGF was 51.9. and her high-sensitive C-reactive protein was 1.3. About 6 weeks later, after starting her on some treatment, which we put her on a statin to help with the CD40 ligand and Maraviroc, which is an HIV medication that blocks the CCL5 or RANTES receptor, and then continued on the fenofibrate. Once that was done, you can see that her RANTES came down a little bit from 12,944 to 12,469. Her VEGF dropped dramatically from 51.9 to 14.6, and her SCD40 ligand actually normalized at less than 9,000. So we continue to kind of treat her with the same kind of management plan, right? So she was put on this pravastatin, Maraviroc. Clopidogrel was a clotting factor that we added in there, concerned about the vasculitis and some microclotting. And at this point in time, her veins were good enough that she could start doing some IV therapies. So we added that in there, put her on some SPMs at this point, 3 times a day, quercetin, CoQ10, increased her D3 to 10,000, increased her CBD to 30 milligrams. All right, so over the summer, she continued this protocol. She was making slow but sure progress. Her MSQ dropped to 55. Her vital signs were now finally within normal limits. Her heart rate was no longer elevated. She still couldn't taste or smell, and she was still very anxious about the possibility of getting COVID again. She wanted to know if she should get vaccinated or not. Interestingly enough, the testing for the testing for long haulers actually looks at their antibodies. She had pretty high antibodies, so we recommended that she didn't get vaccinated at this time. Looking at her labs now, we got her vitamin D up to 64. Her high sensitive C-reactive protein was optimized. Her fibrinogen levels were optimal. Her thyroid levels were looking good. Her cholesterol levels were looking really good. And the two markers from the long hauler panels, the SCD4, CD40 ligand, which had dropped below 9,000, came up a little bit. VEGF was still slowly coming down, and then finally the RANTES was in the normal range. So this time we kind of hit her with the high dose vitamin C. We continued her on the pravastatin maraviroc and added in LDN, and then stopped the clopidogrel. She was continued on SPM. We supported her with some anti-inflammatory supplements and continued her on vitamin C and quercetin. And then we started a fibrinolytic lumbrokinase twice a day to see if we get rid of some of the microclotting. Well, a few months later, she was 80% functionally improved. However, interestingly enough, she went to Hawaii in September. We decided to stop the maraviroc because her RANTES levels had come down, and she fortunately had taken it with her. And while she was there, about 2 weeks after stopping, it started having a recurrence of chest pain and shortness of breath and headaches, and restarted on the maraviroc, and it miraculously resolved all those symptoms. So by December, when I saw her, she was feeling much better. You can see her MSQ was 38, previously 55, and all of the normal lab markers in the COVID long hauler had now normalized, and so we ordered some labs again. So here she was now a year out from when she had COVID. And so she continued on the fenofibrate, low dose naltrexone. We tapered her off of maraviroc again and continued her on the SPM, CoQ10, and put her on detoxification protocol. And that's where she is currently today. So let's talk about some of these treatment options and why, what's the rationale behind using them. So specialized pro-resolving mediators, these are lipid mediators that come from omega-3s, and they are activated in the body through a series of enzymatic reactions and when they are released, these resolvins, and there's several of them, actually help to shift the macrophages from a pro-inflammatory state to a anti-inflammatory state. The same with monocytes. They're helpful in getting rid of those non-classical monocytes so they don't linger. And this seemed to be really helpful in decreasing overall inflammation and supporting tissue recovery. This was one thing that I found that was common among all of my post-COVID patients that really seemed to be helping. The evidence for high-dose vitamin C therapy, particularly in long COVID, it's just not existent yet. So these are anecdotal reasons. However, there was a study done in Nutrients by Volbrock where they looked at 9 different studies, all of which used high-dose vitamin C therapy for chronic fatigue. Most of these were cancer patients, so there was one patient group that this was not a review of 9 studies, it was 9 individuals. It's a study of 9 individuals. And the one individual who had HSV, it was a study. Sorry. That happens when you're trying to do a talk from memory. It was 9 studies, and because they used different doses in each of the different studies. And most of the doses were upwards above 50,000 milligrams or higher. Interestingly enough, the one that was looking at chronic fatigue with the HSV patients That was done at 7.5 milligrams or 7.5 grams, and showed actually improvements in their energy as well. So the dosing may or may not be that important, but getting the intravenous vitamin C up to higher levels will definitely show anti-inflammatory and overall immune modulatory benefits. Vitamin D, there are so many studies looking at vitamin D3 and its impact on preventing not just COVID, but the flu and other things. It has so many impacts on the immune and hormone systems. It's a mainstay. The dose is really kind of dependent upon how low their vitamin D levels are, but there's really no harm in giving them high doses for a short period of time to get their levels up high quickly. And there's evidence to support that that's really beneficial, and particularly in these long haulers. It's not going to be a symptomatic game changer. People don't typically take vitamin D and say, "Oh, I feel so much better because I'm taking my vitamin D." It's just something that is kind of helps to lay the groundwork and helps everything else function a little bit better. Blood thinners. This surprisingly for me was a game changer in treatment of my patients, either putting them on aspirin or clopidogrel. A lot of their chest pain, their headaches, their brain fog significantly improved when we put them on these blood thinners. The difference between clopidogrel and aspirin and lumbrokinase and nattokinase is that the clopidogrel and aspirin prevent the clots from happening in the first place, but the lumbrokinase and nattokinase actually start breaking down that fibrin sludge that is happening along the blood vessel wall. And this is what we're thinking is contributing to some of that air hunger, a lot of the brain fog, and some of the exertional fatigue may be associated because the body's just not able to get oxygen and nutrients into the tissue because there's this fibrin sludge that's preventing oxygen from getting in there. Melatonin, it really has come into light from its an immune modulating aspects through COVID, as the NLRP3 inflammasome modulation has been identified for years, but really came to light and became much more understood during COVID timeframe. So use of melatonin, particularly for anybody who has sleep disturbances, which is often 3 out of every 4 long COVID patients, can be really helpful at decreasing some of the inflammation. It has neuroprotective effects as well as decreasing neuroinflammation of the brain. Flavonoids, quercetin, luteolin are 2 of these that have been studied the most. It's interesting what they have shown in an article published by TRIs in molecular neurobiology. He demonstrated that both quercetin and luteolin were able to inhibit the serine protease required for spike protein processing. There's inhibition of the activation of microglial mast cells, inhibition of the inflammasome and mTOR signaling. So this is something that I have not used luteolin as much, but quercetin, I try and get in 500 milligrams at least twice a day, if not 3 times a day, to help with this. Particularly if they're having more mast cell symptoms, then I will even bump that up to 1,000 milligrams twice a day. So you may be wondering why in the world would we want to use statins for long COVID? And the best way to kind of describe what's happening here is that on the non-classical monocytes, there's a fractalkine receptor, and the platelets release more fractalkine once they're activated, as well as VEGF. And The fractalkine allows this binding process between the non-classical monocyte and the endothelial wall. And this then promotes a lot of leakiness. It perpetuates the coagulation cascade. And so this is something you kind of want to block. Well, statins have been shown to decrease the expression of fractalkine, and it helps to kind of block that binding of the non-classical monocytes to the endothelial wall. So it works kind of like a piece of plastic between Velcro. And the nice thing about this is you don't have to keep them on it for very long. Once their symptoms are improving, VEGF levels are coming down, and if you're using the long haulers, labs, you see their CD40 ligand levels drop, then you can get them off of the statins. But it definitely improves endothelial function. It lowers high sensitive C-reactive protein. So there's a lot of benefits to statins. Pravastatin seemed to be the one that was shown to have the greatest impact on the suppression of fractalkine. So that's the one that typically gets used over the other statins. Maraviroc is a HIV medicine. Dr. Patterson had done a lot of research in his Stanford days on the use of Maraviroc and its benefits in blocking the RANTES receptor. And so the whole goal of what his treatment is in looking at these individuals who then have these elevated RANTES levels and the CD40 ligand. So that's blocking the effects, the pro-inflammatory effects of what the spike protein and the S1 protein are doing to the endothelial wall and this pro-inflammatory cascade. So he recently, this is fresh off the press, this month published in the Frontiers Medicine case series of 16 individuals who were treated with Maraviroc and Pravastatin, and all shown to have improvements in their symptoms as well as their immunological function, which we saw in our severe case patient. Low-dose naltrexone has really become beneficial in treating mast cell activation syndrome. We see it in decreasing pain associated with fibromyalgia and other autoimmune disorders. We're still trying to figure out exactly how it works, but it seems to work through the TLR signaling and helps to reduce inflammatory cytokines such as interferon gamma, TNF alpha, and interleukin-1. Systemic corticosteroids. You'll notice only one of my patients did we end up using steroids. I probably should have used them in my severe case. I think going back and doing it again, I would. These are short bursts. You're looking at 10, maybe 15 milligrams of prednisone, which is not that high of dose. I mean, typically when we're trying to give quick immunosuppression and get the inflammation down, somebody who has Crohn's disease or ulcerative colitis or RA, and we need to get it down quickly, we'll give 60 milligrams of prednisone. So 10 to 15 milligrams is not that much. You're only doing it for a couple of weeks, and then you start tapering down on the third week in maximum 4 to 6 weeks on steroids, at 5 milligram being the dose that they wean off of at the end. This can be really helpful for individuals who are having persistent lung disease associated with this. If they get a CT scan and they've still got interstitial disease, they're having a lot of chest pain and lung symptoms, this is somebody who you'd want to consider adding in these steroids just to calm down the inflammatory response, suppress the immune system while you're getting these other things on board, so that you can definitely help move them along. All right, let's talk a little bit about ivermectin. You guys are probably all over this, but maybe if you don't know, ivermectin was initially discovered back in the 70s and was discovered with a form of bacteria. And over time, it was found to be extremely helpful in treating parasites in animals. It was initially developed as a veterinarian drug, but it started to get used in the 80s to treat onchocerciasis, which is river blindness, and was miraculous in its treatment. It has been used now on almost 200 million individuals with significant safety profiles. So it's not that it can't have problems. There are people who are going to have some side effects to it, mostly gastrointestinal. But the level of safety of this compared to all other medications that are being used for COVID is extremely, extremely safe. How does it work? Well, it inhibits lipopolysaccharide-induced production of inflammatory cytokines. It blocks the replication of multiple RNA viruses, and it inhibits SARS-CoV-2, which has been its most beneficial impact. So it decreases the viral load. So ideally, you want to get this on early, not waiting like my first patient did, who started 9 days into her course. You want to get this started a lot quicker. What we're finding is that in individuals who have long COVID is that when you start the ivermectin, that it helps in decreasing some of these inflammatory cytokines. And if there's reactivation of some of these other viruses, that it can help to downregulate that and helps to really recover. Several of my patients who have had issues with taste and smell, once we start them on ivermectin, it goes away and they get normalization of their taste and smell. However, sometimes once they stop it, it starts to come back. So we'll keep them on once or twice a week for several months, and then try and wean them off again. And if it goes away, then great. Meaning that they can still smell and still taste. All right, let's, in summary then, before I go through this, let me just reiterate that what you guys do as naturopaths is really important. Certainly always focusing on, I didn't dive into this as much as I normally do in a lot of my other talks, because I'm preaching to the choir here. But when I'm speaking to MDs and DOs, a lot of times I will then talk to them about the 5 pillars of health, which is sleep, exercise, activity, movement, nutrition, getting on the right diet, getting nutrient dense, low caloric, low carbohydrate meal plans, and then working on their stress management. We've seen over and over again how stress will reactivate this, make symptoms worse. So helping them with their adrenal support, and then relationships. One of the biggest reasons for individuals to develop long COVID is they feel isolated. They don't feel like they get out and be a part of the community. They're still struggling with symptoms, and so helping them feel a part of the community, building their relationships, can be really important. So that said, let's go into then kind of the way that you can think about this and approach this. Every case is going to be unique, and I hopefully I've given you some ideas and some tools that you can then start to use. I would encourage you to continue to do research on your own, look at the studies that are out there, look at the different experts out there sharing what they're doing and the rationale behind what they're doing. The truth of the matter is that we, don't have good studies yet to support any of the treatments. Most of what we're doing still is from a theoretical standpoint. There's good rationale as to why we're doing this. And so then you will see anecdotal benefits with your own patients, as you've seen from 3 of my patients today. So first of all, think about decreasing the inflammation and promoting the clearing of spike protein, the S1 protein, that's stimulating these monocytes and macrophages to be still pro-inflammatory. Use prednisone in individuals who may be having still lung issues, having a lot of inflammation. You want to kind of get that down quickly. I left off curcumin in there, but I would definitely consider curcumin in this group. Get them on ivermectin. You can start them on pravastatin. Red yeast rice, I just couldn't find any studies. I've used it on one patient. Seems to be okay. It does have statin-like effects. That's where the statins came from. So theoretically, you could use red yeast rice. It's just not going to be as potent. And I just didn't find any studies that it's doing the same thing on the RANTES. Sorry, not RANTES, but the fractalkine receptors, as well as the fractalkine levels. You want to start somebody on CoQ10 if you're going to use the statin to help diminish mitochondrial impact there. We talked about the importance of melatonin, low-dose naltrexone. And then for the more severe cases, Maraviroc is something that you would consider in patients who are just not responding, or if you get the long haulers test, have elevated RANTES in them. Next, you want to think about how can we rebalance the immune system. We want to shift from this pro-inflammatory state to a pro-resolving state. And things that are going to be really helpful in doing that are SPMs. Fenofibrate is a great, safe medication that you can use at low doses to help. It binds to bile. It's a bile resin, helps in a lot of ways. Vitamin C and vitamin D are also going to be critical foundational pieces to that. And then think about this microclotting aspect, particularly in people who are having shortness of breath. If you see elevations in their VEGF, they're having some brain fog, headaches, clotting issues, or rashes. Think about this. And so consider adding in aspirin, clopidogrel, nattokinase, and lumbrokinase to kind of clear out the debris, the fibrin debris. Then lastly, look at these complicating factors, and this is a short list, but obviously there's a lot more that goes into dealing with those, depending upon exactly what you find is contributing to that, which we saw in some of our patients. All right, so obviously there's more that's needed in research. We will continue to, this treatment will continue to evolve. I didn't talk much about long COVID in individuals who have been vaccinated, but it is similar. Some of the treatments aren't quite as needed, like prednisone and Maraviroc. We don't typically use in the post-vaccine because we're dealing mostly with the spike protein. But it's a similar type of treatment. I encourage you to take a look at these different articles. This Nature Review in Microbiology just came out this year. It's really interesting. And if you're interested, go Google the iRecover protocol by the frontline critical care COVID doctors. And they put together their rationale, and it's fantastic. It's 54 pages long. So there's a lot of good information there. All right, well, thank you. I hope this has been helpful, and I look forward to answering some of your questions. Thank you.